Thank you very much for being in such numbers for this course. And I've clicked photographs to tell Dr. Namrata Sharma that this course should go on. So, posterior capsular rent and Professor Madi has shown a lot of scenarios, but this is something that we do definitely need to understand, and the IOL implantation. And that's when you are in a dilemma, you are in a fix, and the chill is down the spine. So this is one of the points of horror for every cataract surgeon when the posterior capsule has rented and you have promised a particular IOL for that patient. So what do? Do you change plans? Do you put that same IOL, or do you do something different? So let us look at this video, and it is a video in which it shows that there's a very large posterior capsular rent. And with this amount of posterior capsular rent, the first thing that has to be done is the high molecular weight viscoelastic that has to go in. And to partition off the large chunk of nucleus from the capsular end, and try and do a phacoemulsification under very, very low parameters if you can get through it. So this demands a lot of energy, a lot of patience, and a lot of viscoelastic that has to go in. The moment you see the tremulousness of the iris occurring, immediately stop. If you feel that vitreous has come in, immediately stop. Phaco has to come out, viscoelastic has to go in, and to do a vitrectomy before you do any amount of phacoemulsification, and that is the rule. Because if your phaco probe is sucking up the vitreous, so what is going to happen is the vitreous base is going to be sucked up, and then you have a problem. So in this case, very luckily, the cataract did not go down and it stayed. Now, you can see that when I have placed in this lens, now the lens, putting it in the sulcus is one of the safest, and then to capture it in the anterior capsule. Safest, it stays strong and stable even if there is capsular dialysis. Now, the most important thing is this part of the final part, you must put in triamcinolone to see if any amount of vitreous is there in the anterior chamber, and to remove the vitreous by vitrectomy before you close this case. That should be, because please do not rely on your eye, on the microscope, on the brilliance of the microscope, because there can be a thread of vitreous which is going to the wound, and that, please remember, it's just not a thread of vitreous, it's pulling right from the vitreous base. So that we definitely need to remember. So now in this, there is a PCR in a mature subluxated cataract, and what do we do for this particular case? So here we have the subluxation is very much there, and it is tough to get a neat and a round rhexis, whatever you need, whatever you require and desire. And here is one situation where I'm putting in the CTR right in the beginning, because I want first a stable bag, and then only my maneuvers can go in. So if there is a partial subluxation, a CTR, as Shubhan just said, has to come in as soon as you need. After the CTR, I still am not very, very sure that my bag is going to be in place. So I put in these iris hooks to support the bag. The capsular hooks would have been better at this stage, but for the purpose of saving a little bit of finances for the patient, we put in this iris hooks. Though, if it requires, definitely put in the capsular hooks. Here again, trouble is there because it is a small rhexis, it's a hard cataract, and all the maneuvers have to be done such that you are able to do it without much of difficulty, without more of subluxation already. So here we are there, and now that's the last fragment that is coming out, and let me see, where are we? So removing the cortical matter, and then removing the iris hooks, and we already have this PC rupture. So I had intended to increase the size of the rexis, but now I will not, because I'm not going to put it in the bag. So we'll put it in the sulcus, and once in the sulcus, because the CTR is there, so if the CTR is there, so you can be sure that at least that bag complex will be there, though the lens is in the sulcus. Again, placing in the triamcinolone and seeing whether there is any other any amount of vitreous. So now let us look again a very large PCR, and in this PCR again, so the PCR, when it occurs, you have to assess the amount of PCR that is there and then take the decision what is to be done at that point of time. And if there's a requirement to change the type of lens that you have actually promised to the patient, it must be done. So as you can see that we have detected the PCR, and before pulling out the needle, you definitely need to put in the viscoelastic. But again, one point has to be kept in mind, that the amount of viscoelastic that you put in must not be so much that it prolapses the vitreous itself, or it goes into the vitreous, and then you have a larger PCR than you had initiated. So here again, it is important to put in the lens in the sulcus. So I'll go on to the next ones. Now here we have another different situation, everything very nice and rosy, and nearly singing a song, finishing my surgical list, and then what happens. So here, when we are nearly at the finish line, there we have a PC rupture, and right in the center. Now if it is right in the center, and if it is possible, do create a PCC, and that's a most important step, where you have to put in a high molecular viscoelastic just to tamponade the PCR that has occurred, and then with the forceps you have to carve out a small PCC. If the posterior capsular rexis is well carved out, this will never extend, and you can put a bulky lens also inside the capsular bag, and that will stay put, that will stay central. But again, the triamcinolone should be there at the end. Now, flax. Promise the patient, oh, you're going to go back to work next day, you can go back to Switzerland next day, and things like that, and then you have a PCR in flax. So it is not only a trouble, it's a mental trouble, and the biggest trouble is how do you face the patient after the completion of the surgery. So even in flax, you can have a PCR despite all these things, and this is a time that I had this PCR, and now removing the amount of the cortical matter has to be very judicious. You have to be very careful that the PCR does not increase. Here I'm putting in viscoelastic as much as possible. At times you can do just a dry aspiration without placing in the irrigation at all, but here you can see that the PCR is behaving extremely well, very sweet of him. So, and it is on the side. So here, since it is on the side, so here again, but this can enlarge. So just don't think that it is on the side. So we just place an intraocular lens, because the moment there's fluctuation of the anterior chamber depth, it can just rip apart. So it's best if it can be converted. You just have to convert it into a PCC, eccentric here, but once it is converted, then you have again a stable bag where you can place in the lens right inside the bag. And of course, creating a little bit of a partition with high molecular viscoelastic to tamponade that amount of PCR. So here again, we can place very safely an intraocular lens, a single piece intraocular lens in the bag. And once placed, it usually stays very central, and if you don't have vitreous in the anterior chamber, then it can stay put as well. So it's important again to place the haptics such that you do not engage the PCR openings at any time. So I'm going to, I'll skip this one for lack of time. So I'm going to show you this, the rest two videos are very, very small. Here we had a PPC, that's a posterior polar cataract, and you can see that, sorry, and you can see that, that it's the typical hammock sign that you have in a PCC, and it has enlarged the. Now, what do we do? So the first thing is with the transverse rupture, the safest would be, of course, to put it in the sulcus, a three-piece lens in the sulcus, capture it, and that's fine. But if you have a situation where the vitreous has not come in, and in many PPCs, the vitreous will not just flood in because they are formed vitreous, and usually in younger patients, and the cataract is also not very thick, then you have the ability that you can place in high molecular weight viscoelastic to tamponade, even this PPC, the PCR, and then place the intraocular lens, landing it on the iris. This is something that Professor Chi has taught me. So the landing has to be on the iris, never first inside the bag, and then curving it down and creating a pivot so that under visualization, it goes into that space between the anterior chamber, the anterior capsule, and the ruptured posterior capsule. Similarly, this side as well, and under total visualization. If this can be done, if this maneuver can be done, then do. Otherwise, if it cannot be done, if there's vitreous in the anterior chamber, the bag has actually collapsed. So there you really will not be able to place it, so do not attempt it. So this is a situation where you can do either ways, but this way is also possible. So the last of my videos is an eccentric longitudinal rip. That the other one was very symmetrical. You had large pockets on both the sides, and the hammock was absolutely transverse. So it's quite good to land it on the pupil, on the iris, and then place it in. But here in this situation, we have an eccentric rupture. Can you see that eccentric rupture? And I'm placing in viscoelastic, and that is a large eccentric rupture right on that. But again, the vitreous has not prolapsed, so I'm placing in high molecular viscoelastic in between the ruptured posterior capsule and the anterior capsule, and then landing it there again on the iris, and this time it has to come into that position where you can actually wield in the haptic into that hammock, that space between the anterior capsule and the ruptured posterior capsule, very judiciously, keep it there, and again pivot it, fold the haptic over, and here of course the quality of the haptic optic junction has to be excellent, otherwise you might actually not be able to maneuver it. So these things are absolutely doable, but absolutely on case-to-case basis, and of course to be very judicious that there's no vitreous in the anterior chamber. Trifocal with PCR, shall I quickly show this? I don't know how much time do we have?
You have all the time.
Acha. So anyway, trifocal with PCR again. So 57 seconds. We might as well show same way. Now in these cases, should you implant or should you not implant? A trifocal, obviously with all the complication of tilt and everything, and obviously a little bit of decentration, the drop in quality, the drop in contrast sensitivity, everything can be a possibility. But yes, here of course again that same technique I did apply. I placed in this trifocal. The patient in the first eye had a trifocal. I said, that I told the patient on the table that we have a problem, but we are going to do the best as of now. Patient obviously was a little scared, and when we usually show our surgeries to the patient party who is waiting outside in the hall, and obviously they came and said, "Doctor, you took too much time this time," and all. So we explained that this is the situation. We have placed the trifocal, but the quality of vision is not going to be as good. So I think in such cases, it's very important to be honest and truthful, and also to tell that if you're at the end of 3 months and 6 months, if you're not satisfied with the vision that you have, there are possibilities that we can exchange the lens as well. Usually, the patient subscribes to the idea, yes, I'm not seeing well, yes, right eye and left eye. Okay, doctor, after 3 months, fine, yes, you said so, okay. So, it's very important to be transparent at these stages as well as to be judicious. So, these are the parts of the horrors that we face every day. Thank you very much. Any quick questions? Yes, please. Yeah. So, yes, it is very important that it has to be removed, and not too much must be placed. Viscoat is something that I use. Helon is something that I use. Helon GV is also something that I use. But with Helon and Helon GV, it comes out in a bolus, whereas Viscoat will not come out in a bolus, and thereby you have to remove those strands of viscoelastic. When you have placed the lens in, when the anterior chamber is stable, you have to go on removing it. And these are points where you have to be sure that you're not also letting the vitreous prolapse again. Because if you're removing the viscoelastic and the vitreous is coming up again you have to go in with the cutter, do a vitrectomy so that the vitreous is not there in the anterior chamber.
Sometimes the lens flips when you put this multi-piece lens.
Yeah.
Okay?
Yes. That's a very good question. See, again, injecting a multi-piece lens, once it is in the nozzle of the cartridge, you have to see how the fold of the haptic is. If the haptic is folded this way, then it just goes in and clockwise you can rotate. But at times it will be folded on the other way. So there you have to reverse the nozzle. The nozzle has to be reversed by the twist of your hand. And then the unfolding should always be so that clockwise you can rotate.
Thank you.
Yes. Yeah, Santosh, we always have a monofocal lens as a backup. And we have here in this particular case, if I could not place it in the bag, I would definitely have a monofocal to place in the sulcus. However, the other technique is you can place a single piece lens in the sulcus, but you have to capture it in the with the anterior capsule. If you can do that, then that lens complex is stable, though ideally it should be in the bag. Yes.
What did you tell the flax PCR patient?
Flax PCR?
What did you tell the patient after the surgery?
I said that we are not going to charge you less. We have spent more of sweat.
Knowing Partha, you said, yes, I spent more time, so more money.
So in continuation to the previous question, you said the patient already had a multifocal in the other
First eye, yes.
So how did you count, if you would have put up monofocal,
Yes.
how would you counsel the patient post-operatively?
Yeah. So again, here again, I'll be very not philosophical at all, but practical, that you need to tell the patient that things have not gone on well as was planned, and therefore for the best interest of the eye and for you, we have done a change of plan, because our patients are under topical anesthesia. At that point of time itself, without scaring the patient, we tell them that this is going to take a longer time. We might have to, even when I have to ask my VR surgeon to take over with a lens drop and things like that, we say that this is going to take more time. 2 surgeries will be required. So again, it's in the best interest of the eye. So the underlying statement should be, we are doing our best for your condition. It is not exactly what we planned, but these things happen rarely. These things have to be told and explained to the patient. And that, over the long years, I think all of us have learned the same way. So it's best to be very transparent. Yes.
Sir, then would you exchange the multifocal in the other eye later?
No.
No, that again is up to the situation. Again, let me tell you, the neuroadaptation, the mentality of the patient, the understanding of the patient is all very important. So usually a patient will not insist that, no, doctor, you just take off this lens, unless it is really giving some trouble after 6 months or so.
But Partha, actually you could do a
Yes.
reverse optic capture.
Yes.
If you had a PCR
Yes.
and you are putting in a trifocal lens.
Yes.
As long as your CCC is correct size and is centered, you
Yes.
can always do that.
Okay,
Absolutely,
so
yes.
just to answer your question, two aspects. One was the patient handling, other was the multifocal. I think it's always best to, whenever we're talking to anybody, it's better to always talk of their interest than our interest. Then in your interest, for your good, and that's a fact. We're just being honest. And I would have done it in my mother's eye, in my father's eye, the same thing. I think they relate very well to that. Okay, that's one thing. Second, multifocal, one-eyed patients I have done, they are very happy. So, having a multifocal in one eye and a monofocal in the other eye, with one having only distance vision and the other having multifocality is no bar. There is no problem at all. They enjoy the multifocality still. Okay, so you tell them that, see, the idea is, I have sometimes patients who have had a monofocal in one eye and want a multifocal in the other eye. So what do you tell them? See, for distance, you'll be using both eyes. For near, using one eye. You want to use both eyes? I'll give you glasses for the other eye.
I think now we have Gaurav. And
Yeah, please, sorry.
Gaurav has to show, and I think we'll have to finish also. So, Gaurav, please. You can.